it is interesting concept that was introduced also around 15 years ago when the high cardiovascular risk strategy was introduced. Two famous epidemiologists, they published a very interesting paper in The Lancet attracting global attention that just taking polypill. A polypill is a pill that contains several ingredients, like 1 or 2 blood pressure lowering medications, one statin, and they also suggested aspirin in the polypill. So the point is that several medications in one pill, easy to take, not to forget taking it, and if it's given, they suggested, to people over 55 years old, regardless of anything, that will reduce cardiovascular disease incidence and mortality 75 to 80%. So that caused a lot of discussion, and there were a number of randomized controlled trials since then, and some were positive, some were not positive, some were even negative. But overall, all the randomized controlled trials, and particularly 3 large recent randomized controlled trials, have been analyzed in a quite sophisticated individual participant data meta-analysis published last year in The Lancet. And the evidence from that meta-analysis was very strong that polypill is effective for primary stroke and cardiovascular disease prevention. I'm not so sure about aspirin component of that polypill. Personally, I would not recommend it for primary stroke prevention, because there was a large aspirin trial done in Australia that showed beyond any doubt that aspirin for primary stroke prevention causes more harm than benefits because of the bleeding complications. So for secondary ischemic stroke prevention, yes, but not for primary stroke prevention. But the point is that polypill is now beyond doubt is a proven strategy for primary stroke and cardiovascular disease prevention. The question is whether it can be used across the globe, all the countries, all the people. No, the answer is no, because in these trials, there were a particular group of people that who were tested by polypill, control or placebo, and active polypill. And people who were tested were at moderate cardiovascular disease risk, which is a risk between 10 to 15% over the next 5 years. And those people constitute about maybe 20-30% of the population. That's number one. So cannot be used to everyone. Number two, the age range in those trials was between 35 and 75 years. So it cannot be used for people over 75 years. There is no evidence for that. It can be, but there is no evidence for that. And there were some other limitations in terms of the patient or subjects eligible for the trials. Like in any trials, any randomized controlled trial has some selection criteria. So results usually cannot be applied across whole population from any trials. And those meta-analysis and 3 large trials are not exemption from that. Therefore, there need to be individualized approach to primary prevention. We should not forget that polypill, that blood pressure lowering statins, lipid lowering medications, they address only two risk factors, though important. Elevated blood pressure is the single most important risk factor for stroke, explaining about 60% of the stroke burden. We cannot ignore it. That's a very important risk factor. But we should not forget about lifestyle factors: smoking, poor diet, low physical activity, excessive weight or obesity, and other some lifestyle factors. They explain about 50 to 60%. In different countries, the proportions are different, but at least half of the stroke burden is due to lifestyle factors. And unlike polypill that acts only blood pressure and lipids, correction of lifestyle factors has overall beneficial effect on the subject, on people, regardless whether all the lifestyle factors controlled or just one risk factor controlled, and not only for stroke, but for a range of non-communicable disorders. So it is the most efficient in terms of the no harm, overall benefit, strategy, lifestyle strategy. And ideal, and that's what we all agreed with my opponent, although Professor Michael Brennan is not real my opponent, he is my good friend for life. We know each other, but yeah, more than 30 years, half of my life. So we're friends. So Michael agreed with me that both strategies are actually complementary to each other. And particularly in countries with very low income, we should not forget about 1 billion people live on income less than $5 a day. They cannot afford going to a doctor. They cannot even afford to measure blood pressure. They cannot buy blood pressure measuring machine. They basically have nothing. And for those people, polypill is a real option to reduce the risk of cardiovascular disease. So we should not forget about that.